My name is Stephen Thompson. I'm a neurologist with the University of Texas and the Texas Comprehensive Epilepsy Program. We're going to discuss what happens when medications don't work and the journey to epilepsy surgery. To begin with, let's talk about the purpose of epilepsy treatment. The goal of treatment is, of course, the goal of seizures. And the goal is equally to do so without provoking intolerable medication side effects. So when that is not possible with medicine, we refer to the epilepsy as being intractable or drug resistant. So again, this is simply when epilepsy has seizures that can't be controlled by medicines. There are a lot of medicines that are available for treating epilepsy. Every year we have more, yet despite this increase in medication availability, about 30% of patients, so 3 in 10, remain intractable, who have seizures that can't be controlled by medication alone. So more formally, we define medication intractability as failure of 2 or more medications. Of course, these have to be appropriate medicines. There are some medicines that may be inappropriate for a particular type of epilepsy, and also maybe medicines that are simply intolerable that can never be used adequately. Those wouldn't count. But if medicines have been used appropriately and the medicine is proven tolerable, just not effective, we consider that to be a medication failure. These are very informative diagrams. This comes from a study that was run over many years, and the colors here are indicating various seizure medicines, some of which you may know. The dotted line in yellow is supposed to indicate the older medicines on one side, so carbamazepine, valproic acid, phenytoin, clobazam, and the newer medicines such as levetiracetam, lamotrigine. As you can see, the type of medicine that patients have been taking over the years has changed. So between 1982 and 2014, a lot of new medicines became available, and patients now typically receive those first. This diagram is meant to indicate how patients respond to any given medicine. So the probability, the chance that their seizures will come under control after a medicine. So when a patient receives their first medicine, a little over 50%, about half the patients will respond entirely and will have the seizures brought under control. If this is not achieved, a second medicine can be tried, and a larger percentage of patients will eventually come under control, but the difference of patients one to the other treatment is not that great. So you only had about 15% or so patients with additive seizure control. After that, the response becomes even less favorable. So by the time you get out to the 4th medicine, you're still under 70%. And as you can see, if you keep adding additional medicines, you won't get over that point. As I said earlier, about 30% of patients have seizures that can't be controlled. So that would be these patients. So that number of 2 comes in from this observation. After a second medicine, the chance of responding becomes progressively less. So once a patient has been on 2 or more medicines, the chance of responding to more medicines is very, very low. So after medicines have been shown ineffective for a patient, or the next treatments that become available are things like neuromodulation devices, like the VNS, RNS, DBS. There are dietary therapies, the oldest treatment, in fact, for epilepsy, such as the ketogenic diet, and then epilepsy surgery. Of this list, epilepsy surgery is the most effective, and it's a topic of this presentation. These other therapies will be discussed in a later talk. Historically, one of the most widely used and effective treatments for certain types of epilepsy is shown in this cartoon. Many people have epilepsies of the temporal lobe. This part of the brain is called the temporal lobe, and this part seen on the undersurface, deep inside, is called the hippocampus and amygdala, and they form the core of the epileptic problem in patients with temporal lobe epilepsy, like this. The well-established treatment for epilepsies of this type is a anterior temporal resection, so the part shaded in red gets removed. This is a very effective treatment. It was studied about 20 years ago in a rigorous way. This is a diagram showing how patients do over time. This is 12 months, so the first year. And this is the percentage of patients without significant seizures. So that's seizures that impair awareness. If patients in this trial were continued on medicine, they showed a very low chance of becoming seizure-free, like that earlier diagram I showed you. If instead they were treated surgically, the chance of seizure freedom was considerably higher. The difference between these treatment arms, these types of therapy, is about, well, is exactly in this trial, 50%. Now, that is a dramatically beneficial therapy. One of the ways that we can evaluate the effectiveness of any treatment in medicine is the number needed to treat, NNT. The number needed to treat in for this therapy in this group of patients is 2. So if you treat 2 patients, you will achieve seizure freedom in one of them. That doesn't mean it's a coin toss. It just means that the therapy has a dramatically improved likelihood of working. Now, to put this in perspective, many of the other treatments in medicine have number needed to treat values of 5, 10, 20. Some of the most widely used medicines, with good reason, still have numbers needed to treat in the hundreds. So number needed to treat of 2 is lower than any other treatment in medicine. It's a dramatically beneficial therapy. So of course, there's a big step to be made between having your epilepsy become intractable and having a surgery performed. And there is a journey, if you will, that needs to be followed. And these are the steps that we'll go over in short order. The first step is, of course, dependent on you or on your primary care doctor or the neurologist who takes care of you, and that's referral to a comprehensive epilepsy center. So a comprehensive epilepsy center is able to do all of these next steps, including a surgical evaluation. Unfortunately, many patients are not referred in for many years. We regularly encounter patients who have been intractable for decades before they're eventually referred to our center or other comprehensive centers. We'll go over each one of these steps, the appointments with epileptologists, neurosurgeons, and what we refer to as phase 1, 2, and 3, the epilepsy monitoring unit, which is where a lot of this work gets done. I think there's a separate talk detailing the specifics of an epilepsy monitoring unit. So to begin, after the referral is made, you'll meet with an epileptologist. This is a neurologist who has specialized training in the treatment of epilepsy. So they've had the usual medical school residency for the neurology training, and then have done additional fellowship training in epilepsy. A number of things happen at this appointment. A lot of clarification will be had. Some of the things that the epileptologist will certainly ask you is the age that your seizure started, whether or not there are particular risk factors for epilepsy. These could be things like febrile seizures as an infant or young child, head traumas, family history. There are many things that need to be considered. The frequency of seizures, both currently and over time, and importantly, what medicines have been used and what was the result. Did you take it and then have it not work, or did you take it, something happened that made you intolerable of it? One thing that will be crucial and is one of the key points from this appointment is an understanding of what the seizure looks like. We refer to the semiology, which is a word that simply captures the symptoms and the signs of the seizure. So how does it feel for the patient? How does it look like to witnesses, to family members? And it's very helpful to have witness accounts for this. So in the appointment, the patient will be able to describe as much as he or she is able, what the aura is, for example. That's often a sensation that you may have at the very beginning of the seizure. Unfortunately, many patients become unresponsive and can't remember anything beyond that point. So having a witness, family member, close friend who's seen these seizures is very helpful. And in recent years, cell phone videos have become quite helpful. So if a family member, a friend is able to videotape on the cell phone what the seizure looks like, it would be very helpful to review in clinic. And we do this, we dive into these details because knowing what the seizure feels and looks like helps us understand where it may be arising from in the brain, which is a key consideration for any surgical intervention. We need to know where the seizure is coming from to determine both if it's a type of epilepsy that can be treated surgically, and then if it is, where in the brain it may be coming from. So at the end of this appointment, various things could happen. There could even be an adjustment made to medicines, certainly a scheduling of studies, and it's an important time to discuss concerns, both about previous history of epilepsy and the upcoming steps. So the first major step referred to as the phase 1, which is recording in the Epilepsy Monitoring Unit, or EMU. This is an opportunity to do continuous video and EEG monitoring. You've undoubtedly have had electrodes placed on the head for an EEG. This would be done over the course of many days. And the purpose here is to record the seizures, as well as any EEG abnormalities that may be occurring between seizures. Patients can have a lot of abnormalities on their EEG without them having actual seizures that are very helpful for the epileptologist to understand. So the seizures are referred to as the ictal changes, and the between seizure, the interictal. Now this is typically a 3 to 5 day stay, which of course suggests we need to do something to bring about seizures. You may have seizures on a monthly basis, and we need to try to capture them within a few days. So very often there'll be a reduction in medication, something that wouldn't be safe to do on your own at home, but that can be done safely in hospital. We may sleep deprive the patient or use other provocative measures to help bring about seizures. All these things are done under constant watchfulness. The nursing staff and EEG technologists are constantly watching on the video monitor for seizures and able to interact and intervene if needed to keep patients safe. So We bring patients in to actually record seizures. Don't worry about what this means. It takes a lot of training to understand this, but seizures can be picked up on the EEG. That's what this shows. The other major step, and often done at the same time as the EMU, is the MRI, so the magnetic resonance imaging, which is a very high resolution picture taken of the brain. You probably had MRIs or CTs done before that. We will always review those and then most often repeat our own, because we have a very high resolution MRI to do very detailed imaging. And here we're looking for anatomic, so structural, physical abnormalities on the brain that could account for the epilepsy, what we would call a lesion. And these can be sometimes very obvious, but often quite subtle. And we'll often find something that had been overlooked for many years that relates to why the patient had seizures in the first place. So to help with this, a skilled neuroradiologist with expertise in epilepsy will review the MRIs. This is usually very, very helpful. So there are a few pictures here of fairly common forms of epilepsy, and they relate to certain abnormalities in the brain. One that's very common is hippocampal sclerosis. This would be seen in a patient who had temporal lobe epilepsy. This is the hippocampus, and this one on this side is actually quite diseased, and to someone who knows what they're looking at, it's quite obvious. This other patient has a hippocampal sclerosis, but it's much less obvious, quite subtle, and without a very expert diagnostic training, it will be overlooked. Focal cortical dysplasia refers to abnormalities in the folding and structure of the brain. Developmental, so patients are born with these, and are a common source of focal seizures. Here, again, there's an abnormality. An arrow is indicating it, which, if you know what you're looking at, becomes quite obvious. This is a separate patient, another patient who has an abnormality in a similar location, but this one is much, much less obvious. But again, having an expert set of eyes take a look at it can convert a situation where the MRI appears to be normal to one where there is a clear-cut abnormality, which is very helpful in terms of sorting out what needs to be done surgically. So there are other techniques that are available. I'm not going to go into these in any detail. There's a type of imaging called positron emission tomography, or PET, which looks for metabolic abnormalities. This patient has a clear-cut area of metabolic abnormality in the brain. There's another type of imaging called Spect, single positron emission tomography, which can be used to highlight areas of the brain that are seizing, where the blood flow goes. Again, can be very helpful in sorting this out. And finally, a very specialized type of recording called Magnetoencephalography, which can be used then to highlight areas in the brain that are producing electrical and magnetic abnormalities that are abnormal. These all come from different patients and are pointing to different areas in the brain, but in each case, these studies were very helpful in further understanding where seizures may be coming from. And then in some patients, even after all of these tests, there may be unknowns, and to better understand the basis of the epilepsy and to plan a surgery that is safe, intracranial monitoring may happen. Here, electrodes are placed within the actual brain, done under careful neurosurgical guidance, and the recordings come directly from the surface and interior of the brain. these can be reviewed as well by the epileptologist. This is done in the epilepsy monitoring unit as a phase 2, and again, not every patient needs this, but we use it when needed. So the goal of all of this, the goal of the pre-surgical workup, is to determine where in the brain seizures are being produced. We refer to this as the epileptic focus. And equally important is determining where in the brain important functions reside: motor control, language, memory, vision, hearing, all of the things you wouldn't want compromised by surgery. Having both of these understood allows for safe and effective surgery to be planned. These are equally important in our view. So we want to do a surgery that's effective, but only if it's safe. So these have to be considered all along the way, whether something can be done to help cure the patient of their seizures, but in a way that is safe. And all of these decisions aren't made by one person. They're not made by a single epileptologist or surgeon. They're made in a multidisciplinary conference where there are multiple opinions offered, and from people who have complementary skill. This is where we make decisions about whether additional testing is needed or where phase 2 is needed. And once all of the information is gathered, what the optimal intervention is for that patient, whether it be surgery or neuromodulation or something else. So it all comes about through a panel consensus. And then finally, and possibly before that point, the patient will meet with an epilepsy neurosurgeon. This is a neurosurgeon who has specialized training in surgeries for epilepsy. And here, of course, they'll need to clarify with the patient the exact plan for the surgery. You'll need to understand any risks that may be involved. And, very many patients will have appropriate concerns, and they can all be addressed at this point. And then finally, the goal is to achieve an epilepsy surgery. And again, there are many types of this, and this will be expanded upon in later talks. One thing that our center and others have been trending towards in recent years is minimally invasive techniques. So this is treatment for a patient who has temporal lobe epilepsy based on the hippocampus. That early diagram I showed you of the anterior temporal resection, where a fairly large area of the frontal anterior portions of the temporal lobe was removed. Patients with this type of epilepsy can also have treatment done less invasively. Here, a laser probe is passed into the brain, and heating is used to basically thermally destroy the area instead of opening the skull and removing it surgically. The area can be ablated this way. And there are many things to consider as to whether or not this is an appropriate treatment. So just to make you aware. So the take-home points from this are that if medications have failed, further medicines are unlikely to work. And again, the number that we look at is 2. And in this case, epilepsy surgery needs to be considered. Referral to an epilepsy surgery center needs to happen. Obviously, all the steps that I've gone through can't happen if you haven't been referred to a center that could do them. So in the first step is upon you and upon your referring doctors. The rest of it can be taken up by the center. We can't find you. You need to find us. Epilepsy surgery is the most effective treatment in medicine. It may sound like a bold statement, but it is a supported one. I showed you the diagram earlier that outlined that. The journey to epilepsy surgery can be complicated. I've just run a lot of very technical things past you, a lot of terms that may be unfamiliar. They are familiar to the people doing them and using them. So that every step along the way, there's an expert trained. No one person has a understanding about every step, but in combination and in a conference, a multidisciplinary setting, patient cases are considered and plans are made accordingly. I thank you for your time. I hope that this was was informative.